Thank you very much, Bruce. Very grateful. We are very grateful to you for that very clear exposition of the thinking behind the changes to NHMRC funding and the detail that is important to people considering applying for funding, not necessarily immediately, but in planning your future research career. Second presentation comes from Dr. Tony Penner, who again is no stranger to Western Sydney, and he has taken on the directorship of the Office of Health and Medical Research within the Ministry of Health in New South Wales, and I don't want to be patronising too much, Tony, but I think you've done a fantastic job in moving the contributions with the enthusiastic support of Minister Skinner, from being simply a funding agency for infrastructure to one which is taking initiatives in fields as varied as new devices and translational research. So Tony, it's a great pleasure to have you here this afternoon. He's struggled from his sick bed to be with us, so don't shake his hand afterwards and make sure that doesn't cough on you or do anything. But Tony, we look forward very much to what you have to say to us.
So, is that that one yours?
Great, and I'll just thank you for thank you, Steve, and thank you for inviting me to talk today. So, if you're going to only take one thing away today, it's the bottom left-hand corner. We have a Twitter account. Seriously. So we launched it on Tuesday for the medical devices launch on the Tuesday night, and my office was inundated on Wednesday like you would not believe. So the lesson, and it's been told to me many times, communicate, communicate, communicate. So there we are. That's the most important thing. And we'll tell you a lot more. So what I want to be able to do is just give you an outline of some of the things and background to a lot of the things that we're doing, and focus on medical devices and the translational grants, mainly because they're the big players at the moment. But we have other grant systems that are in play that we will enhance over the next year, which I'll say something about, but I can't say too much other than knowing that it's in the pipeline. And that's around the translational genomics and around other areas in that space. So this is, I took the slide out of a slide that our secretary gave to all the other agencies in the state. And one of the really important messages that I can say right at the moment, we're in a time where New South Wales Health, the Commonwealth Department of Health, is so receptive to research. It's something that you really need to take advantage of. At the moment, last week I was told that the Commonwealth Department has its fourth pillar in all the things it does, and that fourth pillar is research. And our secretary spoke last week to all the agencies across the state about the economic benefit of research, and she's totally sold on research, and I'll show you a few more slides. Clearly, what it shows here is that in Australia, and we're an ecosystem no different from the rest of Australia, is that we are very good at innovating and being creative. What we're not very good at is translating. And this is about commercialisation, but it's the same thing that in the whole area of implementing evidence, whether it's generated locally or adopted from St. Elsewhere's. And it's something that I would, there's a video clip that Don has on our translational research grant scheme that I would encourage you to look at, because it really highlights the whole translation pathway, and he highlights the need for us to do better in that space. So why is New South Wales strong? And it is, and I'm not saying this just because you're here. We are a very diverse population. We have excellent education, excellent health system, we have excellent workforce, strong clinical networks. Our LHDs are organised in a way that no other health department, health jurisdiction is currently organised. These are things that we should really mobilise on. That's our LHDs, and we have another slide that I haven't got here that shows how the local health districts are brought together in the geographical hubs and the AHRTC. So we have structure, which is important. So if there was something to, this government, this is the second term, the first term, if you had to identify, there was a lot of funding towards medical research support program, clinical trials, biobanking and so forth and so on. If you had to define the first term of government for, the first term for this government, it's around commercialisation. That was the big translational step that Minister Skinner put on the table, and we learnt a lot from that. And we've learnt, and I'm picking up a lot of phrases that's in Don's clip, but we learnt on the job. And I'll say a little bit more about that. We presented the fifth round on Tuesday, and so that defined a significant translational component to research. If we're going to define this term of government, it's about collaboration and translation in the clinical side of things, in the health services research, clinical research, and so on. Absolutely critical. But let me put it to you that we're not ignoring the biomedical side of things and the basic sciences. That is in our radar for the next few years, so watch this space. But so these are all those that are in red are the ones that we've generated over the past in this current term. The Genomics Collaborative, $24 million went across there. It engaged a lot of players across the space. I won't say much more other than that there will be a continuation of support for the whole omics area, just not genomics, over the next 4 years. And what other things that are important? The early to mid-career and PhD scholarships, we'll certainly continue that in the next tranche. I'll say a little bit more about that. So this is, I want to highlight this, if you haven't seen it before, it is something that so I said the first term was really about driving commercialisation, translation. Our second term is really about driving translation into really the bottom end and also the top end, but more so on the bottom end. And this is driving towards value-driven care. Again, it's a slide that I borrowed from the Secretary. She really believes in this, so very supportive of translational research, and we're going to drive change through a lot of our programs to provide value-driven care. So, and this is something that clearly MRFF is also focusing on. Now I just want to, I'll go back. So I want to say something about the Medical Devices Fund. So I think we've given about over 30-odd million, closer to $40 million over the past few years on medical devices, and the whole translation from a prototype to almost to the marketing phase. And it was created really to drive us to probably have the next ResMed and Cochlear, to build a real ecosystem around med tech and to bring sort of more economic success to New South Wales, and also value for our patients. So one of the key things was that IP had to be in New South Wales, that it had to, if you were successful, the grant was undiluted, meant that we took no equity in it. If we were successful, the money then was repaid, and it increased the sort of amount of money that we can give into future years, and that the health system would adopt the technology or innovation at a reduced cost, a subsidised cost. There have been lots of learnings in this area. When we started, literally the only person who had any clinical input was me, and it was just bizarre. We sooner or later we quickly added a few other players, and we developed a whole clinical review, something that's quite unique in this whole space. And one of the challenges we had early on is that a lot of the players had no concept of how to connect with the health system. Zip. they would just get on an email distribution list and flick it to everybody, and I'm sure that ended up as spam. These were people that had highly innovative and creative ideas that went nowhere. And a lot of the players thought about their engagement with the sector in strange ways. And some of the opportunities that they had, there was almost like you had, and I'll say something about this later, you had solutions looking for problems, and we often say we want problems looking for solutions, but in fact there are opportunities in both spaces, and these players had really smart ideas but couldn't link in with the system. And if the clinicians weren't there to support them, and we're having this right up to the fifth round, the clinicians, and this is an important thing that I've really come to accept most recently, I'll tell you the story around a Triggs program in the next set of slides. But if clinicians, now I'm saying clinicians, not clinician researchers, I'm saying if clinicians aren't involved very early on to frame the problem and look at the solution, the likelihood of success is very small. And so you really need to really look at those stakeholders and to really broaden the input into the thinking around what sort of support you give to an innovation. If you just focus on clinician scientists, who are obviously the brilliant players, and a lot of you would regard yourselves as clinician scientists, but you know as well as I do, an innovation can't occur just through yourselves. You need the broader church of clinicians in your group to support you. And if you don't do that well at the beginning, it's a nightmare to try to address it down the track. And I can give you many. I've had over the past 3 or 4 years, I've looked over 1,000 applications, a lot of them full applications, and a lot of them great ideas. And some of them cannot progress because they haven't had the support of a key group of players. And I'll mention that further. There was, for example, one group here, a great idea picked up by a biomedical person and a physicist to drive a portable infusion pump. Fantastic. It was more reliable, more accurate than the Baxter pumps. They tried it out in a particular place. It was developed in New South Wales. They tried it in Western Australia because they couldn't link in with the system here. It ticked all the boxes. And when, at the end of the trial, it was really fantastic. At the end of the trial, they asked the charge nurse, the nurse unit manager, would you use this in your backyard? And the answer was no. Why? Because it was too disruptive. That meant that the cost of actually delivering the work moved from pharmacy to the nursing staff, and they weren't prepared to do it. So the actual design of it was a real big issue. So Triggs. So the uniqueness of Triggs, and we're going to put more money into Triggs, the uniqueness of Triggs is that it's an iterative model, really supporting people through the expression of interest phase right up to full application. So we have a helicopter view of what's happening in the state, and we try to help with applications. Again, I can't stress how important the whole clinician engagement is, just to give you an idea. So most recently, a project was funded by Triggs, enormous at our highest level, at about $1 million. And it had all the elements of what we wanted. Both the LHD wanted it, the ministry wanted it. It ticked all the boxes. You cannot believe it ticked all the boxes. What we stressed was that it had to be implementable and scalable. So people in the ministry met with them, I met with them, we went through it all, we all understood where we were, fantastic, about to deliver it. A month later, and this is only a month, about 2 months ago, a month later, I get an email and the chief investigator says, I've lost the will to live. You've asked me to try to go outside of my space to see if this could be implemented. So the two supporters were clinicians, scientists, brilliant, but when she went to the broader group of clinicians, there was no way, she said, I could really pull this off in 2 to 3 years. I would have had to have had all of their support before I'd go forward. So I had the LHT chief executive involved, I had the directors of research involved, and they agreed that the project was fantastic, but they needed a lot of work with their clinicians, really important. So some of the quick questions and tricks and from both. So we talk about, you need to define the problem and then work out a research question and look for the solution. But I tell you, the solution for looking for a problem, don't ignore them, because serendipity always picks up things like this, and so you've got to be ready for a solution that will land for a problem that you weren't even aware of. So although I totally support, and that's what we drove, problem looking for a solution, don't forget the solution looking for a problem. And so for me, it links to one of the other things, I think the fifth point, how to navigate the system. If I can stress how important it is, the health system is complex. There are so many players who want to work with us, and they just don't know who to talk to. And when I look at our colleagues interstate and how they've driven change in Melbourne Health, you know, they strategise around linkage around people knowledge brokerage. You might think, well, that's a very soft science. Let me tell you, building relationships with big pharma and medtech, working out what they want, what we want, and so forth, so critical to moving ahead and getting funding. So really important. So you'll find that people who've got a solution knock on your doorstep. They've got to know who to talk to and how you link them. Clinician engagement, I mentioned how important that is. Look, so many collaborators are added to a TRIGS program that add no value. And one of the things that I've looked at and was challenged by was the very fact that a lot of players are on that list, and you have a very poor study design, and you see all the players there that are just superb. Why didn't the study get a better structure? So, and the last one is the enormous need for education, training, mentoring and guidance. So we're going to put more money into it. The MDCTP created a medical device commercialisation training program, an elite program, and also a health directed program helping people to understand medical technology and its commercialisation. And hopefully a lot of people from this LHD and other LHDs are going. It's highly regarded. And we're going to focus also on translational research, working with the Sachs Institute and the Ministry to do an online training course for translational research. And so that's a little bit more about that training program. I don't want to say much more. These are the things that we're going to continue. So there's going to be money. The programs I've mentioned will continue, and I'm looking to enhance a little bit more. And I'm also looking to see if I can help with that idea in the basic sciences, that the value of death towards the prototype, and seeing how I can enhance that. So they are things for the future. And again, the Twitter account is the most important thing. Okay, thanks, Steve.
Thank you, Tony. If people want to find out what grants and so on are available, can they just send you a Donald Trump tweet saying...
Yeah, absolutely.
So, and will things be put out on that account saying, wake up, it's time to put in a new TRIGS grant application, or... So that'll be quite a good point of contact for people wanting to know whether what you've got matches what they want. That's great. Excellent.